Still's disease and adult onset Still's disease, AOSD, are related conditions but occur in different age groups. Here are the main differences. 1. Age of onset. Still's disease, systemic juvenile idiopathic arthritis, or SJIA, typically occurs in children under 16 years old. Adult onset Still's disease, AOSD, occurs in adults, usually between the ages of 16 and 35, though it can present at any adult age. 2. Terminology. Still's disease often refers to systemic juvenile idiopathic arthritis, SJIA, a subtype of juvenile idiopathic arthritis, JIA. AOSD, a similar systemic inflammatory condition but diagnosed in adults. 3. Clinical features. Both conditions share key clinical features: high spiking fevers, salmon pink rash, polyarthritis or oligoarthritis, sore throat, lymphadenopathy, hepatosplenomegaly, elevated inflammatory markers, ESR, CRP, ferritin. However, the symptoms in children with SJIA may present differently than in adults with AOSD, particularly in terms of the progression and severity of arthritis and systemic symptoms. 4. Disease classification. Still's disease falls under the classification of juvenile idiopathic arthritis. AOSD is considered part of the spectrum of systemic autoinflammatory diseases. 5. Prognosis. Still's disease, SJIA, if diagnosed early and treated appropriately, children can often achieve remission or have manageable disease. However, some cases may progress to chronic arthritis. AOSD. The disease can either be monophasic, one episode, intermittent, recurrent flares, or chronic, persistent arthritis and systemic symptoms. In both cases, treatment focuses on controlling inflammation and preventing complications, often involving NSAIDs, corticosteroids, disease-modifying anti-rheumatic drugs, and biologics like IL-1 or IL-6 inhibitors. Yes, many experts consider systemic juvenile idiopathic arthritis, SJIA, or Still's disease in children, and adult onset Still's disease, AOSD, as part of the same disease spectrum, differing primarily by the age of onset rather than their underlying pathology. Both conditions share similar clinical features, laboratory findings, and treatment responses, suggesting they are likely manifestations of the same systemic autoinflammatory disorder. Here are the key points that support this view. 1. Shared clinical features. Both SJIA and AOSD are characterized by fever, salmon pink rash, arthritis, and systemic inflammation. They present with similar patterns of symptoms like spiking fevers, arthritis, and multi-organ involvement, lymphadenopathy, hepatosplenomegaly, serositis. 2. Pathophysiology. The immunopathogenesis of both diseases is similar, with a key role played by pro-inflammatory cytokines, particularly IL-1 and IL-6. The overproduction of these cytokines drives the systemic inflammation observed in both conditions. 3. Laboratory findings. Both diseases often show elevated markers of inflammation, such as CRP, ESR, and notably hyperferritinemia, high ferritin levels, which is a hallmark in severe cases. 4. Genetic overlap. Although not entirely understood, genetic predispositions to systemic autoinflammatory conditions may contribute similarly in both children and adults. 5. Treatment approaches. Therapeutically, both conditions respond to similar medications, including corticosteroids, NSAIDs, DMARDs, and biologics targeting IL-1 and IL-6, further supporting the idea of a shared disease mechanism. 6. Disease course. Both SJIA and AOSD can present in monophasic, polycyclic, recurrent, or chronic forms, with significant overlap in how the disease behaves over time. While the age of onset is the primary distinguishing factor, the similarity in clinical presentation, immune mechanisms, and treatment responses has led many to believe that they are manifestations of the same disease at different life stages. Therefore, it is reasonable to consider them as one disease entity with age-specific classifications. There are several reasons why systemic juvenile idiopathic arthritis, JIA, remains classified within the juvenile idiopathic arthritis, JIA spectrum, and distinct from adult onset Still's disease, AOSD, despite their clinical similarities. These distinctions are due to historical, clinical, and practical considerations. 1. Historical classification, JIA as a pediatric condition. Historically, juvenile idiopathic arthritis, JIA, was created as a broad category to encompass all forms of chronic arthritis in children. Systemic juvenile idiopathic arthritis, SJIA, was classified within this group due to its onset in childhood and its chronic, arthritis focused presentation, even though its systemic features set it apart from other JIA subtypes. The term Still's disease originally referred to what we now call SJIA, and only later was used to describe similar cases in adults, AOSD. This has led to a historical precedent for keeping the pediatric and adult forms distinct in nomenclature. 2. Pediatric and adult specializations. Pediatric versus adult rheumatology. SJIA is typically managed by pediatric rheumatologists, whereas AOSD falls under the care of adult rheumatologists. The healthcare systems, training, and approaches to care differ significantly between pediatric and adult medicine. Combining the two conditions into one might blur these specialties' boundaries. Children with SJIA often face different developmental, growth, and psychosocial issues compared to adults, necessitating specialized care that fits within pediatric frameworks. 3. Arthritis predominance in children. Arthritis in SJIA. While both SJIA and AOSD are systemic autoinflammatory diseases, arthritis tends to be a more dominant and persistent feature in children with SJIA. In contrast, adults with AOSD may present with a more systemic inflammatory picture, with arthritis potentially less prominent, at least initially. This distinction in how arthritis manifests is important in treatment considerations, as pediatric rheumatologists often need to focus more on long-term joint health and growth issues in children. Heterogeneity of juvenile idiopathic arthritis. JIA spectrum. JIA includes multiple subtypes beyond SJIA, such as oligoarticular, polyarticular, and enthesitis-related arthritis. SJIA was placed within the JIA spectrum to help rheumatologists recognize and manage the broader heterogeneity of childhood arthritis. Removing SJIA from the JIA classification could complicate how childhood arthritis as a whole is understood and managed. Research and clinical trials, distinct research pathways. Research into treatments for pediatric and adult forms of Still's disease has often been conducted separately, with specific drug trials for children and others for adults. By maintaining SJIA within JIA and AOSD as a separate entity, it allows for clearer clinical trial designs, drug approvals, and tailored treatment strategies for each population. 6. Age-related differences in disease presentation and outcome. Children versus adults. While the underlying disease process is similar, age can influence the disease's clinical course, treatment response, and long-term outcomes. Children, for example, may have different rates of chronic arthritis or systemic complications compared to adults, making it valuable to keep these distinctions in classification. 7. Legal and insurance implications. Regulatory and insurance frameworks. In many countries, diseases are categorized differently for children and adults, affecting how treatments are approved, covered, and delivered. By keeping SJIA within the JIA classification, children may have easier access to pediatric-specific therapies and insurance coverage appropriate for their age group. Conclusion. Whilst JIA and AOSD are likely manifestations of the same underlying autoinflammatory disease process, the classification system retains the distinction between them primarily due to historical precedents, differences in age-related presentation, specialization in care, and practical considerations in research, treatment, and healthcare organization. Combining them under a single label of Still's disease might simplify the nomenclature, but would require significant adjustments in pediatric and adult rheumatology care, research, and policy, which are currently better served by maintaining the distinction.